Hello, everyone. So my name's Karen Bertulis. I work at the Edward in Plainfield, right off 127th and Route 59. And I wanted to give you an overview of pelvic physical therapy and how it can help your patients. Now, we have a team of physical therapists. We have 3 locations at Edward, the one in Northern Plainfield off 127th and Route 59, the IMED building, which is off of 75th Street, and it's on the 1st floor, and then the Forge Drive facility, which is off of Route 59 in Southern Naperville. So again, 3 different locations, and we have 6 clinicians, and I'll introduce them later. Now, I wanted to go over pelvic physical therapy. And what is pelvic physical therapy? Now, pelvic physical therapy helps restore urinary, bowel, and sexual health, but it involves the muscles, the joints, the viscera, and all the pelvic floor musculature. And again, our Edward physical therapists are specifically trained in this area, and they have a foundation in orthopedics prior to becoming a pelvic physical therapist, and certain ones have certifications like I do in pelvic physical therapy. Again, current evidence supports the use of using pelvic physical therapy as a conservative treatment approach for everything from incontinence, urinary and fecal incontinence, bowel dysfunction, pelvic pain, and pelvic organ prolapse. Again, physical therapy is a successful option that's least invasive. It doesn't necessarily involve surgery or medications or invasive procedures, but a lot of times we have a collaborative effect where we're going over diet, medications, bowel and bladder retraining, and or surgical procedures as needed. Now, here's some common pelvic physical therapy conditions that I treat and our team treats. Urinary fecal incontinence, and that's more of a strengthening program if no pain component exists. Next, painful bladder syndrome, or IC. Then diet modification plays a big role in this, and sometimes a dietitian is involved also. Constipation. Be careful when you refer your patients for constipation. Make sure you put other IC-10 codes such as dysgenic defecation, slow transit time, and abdominal pain. Again, all these different IC9 codes are helpful in treating pelvic floor, so make sure you put these constipation IC10 codes and pelvic floor dysfunction. Next is pelvic pain, everything from vaginismus to dyspareunia to anal spasm. Again, these pain complications are more complex. There is no strengthening involved. It's more manual intervention, more diaphragmatic breathing, parasympathetic nervous stimulation, yoga-based. Again, very modified yoga-based. Next, coccydynia, tailbone pain. Now, this is common with my patients who've had posterior occiput presentation with their delivery, and their tailbone's an extension, hyperextension, so manual rectal intervention is involved, where you're distracting the coccyx and doing a manual mobilization, and sometimes even like sporting injuries. So the youngest I've treated was 13, the oldest maybe 85, depending on the whole spectrum. Again, pelvic organ prolapse, cystocele, rectocele, urethrocoele, vaginal vault prolapse. Pregnancy-related musculoskeletal dysfunction. When my patients are pregnant, they have hormonal ligamental laxity due to the pregnancy hormones. So then you see more pubic symphysis separation, tendinitis, and SI dysfunction, and that's where we have more manual interventions and belting if necessary. I also see women postpartum, and in Europe it's pretty commonplace to see a physiotherapist or a pelvic physical therapist. And again, you see everything from rectus diastasis to perineal lacerations, maybe due to infection or severity of tear. Pelvic organ prolapse. Conservative treatment is the first line, especially if they want to have other pregnancies and vaginal deliveries. Coccydynia that I discussed before, and incontinence, fecal and bladder. Now, there are many different treatment options. Internal and external manual therapy to increase the soft tissue, the viscera, and the joint mobility. Biofeedback. Now, this is nice for my patients to gain awareness. It measures the action potential of the musculature. And I use either a rectal or vaginal sensor, and you'll see them later in a slide, to help a patient appropriately control and coordinate these muscles. I want them to fully contract. It's easy to think about the bicep. Fully contract, relax, but also bulge for sexual health and bowel health. Neuromuscular reeducation, more Pilates based. And this is quite complex because some patients have no awareness. So it's a lot of retraining of the muscles of the core, which is the levator ani and the transverse abdominis. And we also have to look at the joints that surround this area, the lumbar spine, the ilium, and the SI joints. Now, bowel, bladder, and diet education, so important. It's the crux of everything. In order to reduce urinary urgency, frequency, leaking, and pelvic pain. Now, education, again for all of us, education is so important because your patient needs to understand why we're doing what we're doing, understand the anatomy, the pathology, but in layman's terms, and why they need to do their home program. So really, that's probably the most important thing I could give you today is patient education materials. And you'll see some handouts you could use with your patients later. Again, modalities are important to assist with pain, strength, and urgency, and I'll show you some modalities that we use, and I think you use something similar for posterior tibial nerve stimulation. Now, upon assessment, we do a PERF scale. It's developed by Laycock and Brink, and again, it measures power. Now, there's an Oxford and Harvard scale, and you can see the different grading of the levator ani from 0 all the way down to 5. And of course, 1 is trace. You get a flicker or a squeeze. It's digital vaginal assessment, but you can also do it rectal if you want to measure the external anal sphincter. 2 is poor. You get a contraction or squeeze, but it's more asymmetrical with no displacement or lift. 3 is a fair contraction. You're getting more displacement, usually posterior only. Versus 4, you get a squeeze and contraction or lift, anterior and posterior, but then some kind of pull inside the vagina versus strong. 5 out of 5 would be someone who never had children. And they have full squeeze grip and an inward pull. Again, I'm measuring for endurance. Can they do a 10 count hold and 10 repetitions? Then I also measure the fast twitch fibers, how many fast twitch contractions they can do in a 10-second timed interval. So that is my PERF score that you see. Again, we're looking at the endurance fibers, the slow twitch fibers at 70% of the pelvic floor versus the fast twitch are 30%. So we need to look at both muscle fibers. Again, I want to evaluate my patients. Remember, they're in supine hook lying, so no gravity involved. Of course, as you will, gravity greatly affects prolapse, but I'm going to have a patient perform a Valsalva maneuver in the supine hook lying position. I'm assessing for minimum, maximum, or moderate descent from the anterior, posterior, and apical wall. I'm also looking externally at the mobility of the bladder suprapubically, uterus, if they have tenderness at the ovarian area, and colon too, small intestine, large intestine, and if they had maybe a diastasis affecting their core stability or possible hernias. And then once I'm assessing internally, I look at trigger points. Trigger points are really tender spots to the touch versus a muscle spasm is just like guarding in comparison. But you look at both and you can grade it depending upon the patient. And I explain everything with a pelvic model so a patient feels comfortable and understands the importance of the assessment. Pelvic floor anatomy. Again, this is what we do. It's the crux of what we do. You can see our anatomy here. Now, first you have the urogenital triangle. And I know Dr. Jersley mentioned a patient earlier with different issues where her bulbocavernosus, right here, that rounded muscle, the guardian, was so spasming it wouldn't allow any penetration or speculum insertion. And probably with that patient, tampon insertion too. So the next one is the ischiocavernosus, the triangular muscle, versus the superficial transverse perineal muscle. Again, they're all innervated by the pudendal nerve. And that is the first layer of the urogenital triangle. Versus the urogenital diaphragm, the deeper musculature. Again, pudendal nerve innervation, but you have the deeper transverse perineum and the urethra compressor right in front. And you can palpate that on either side, telling a patient to squeeze like they're going to stop urination, but tell them, this is just a one-time test with me. I do not want you squeezing or pushing your urine out. So I make sure I kind of tell them right away that's not something I want them to do except for once with an assessment with me. versus the deeper layer, the pelvic diaphragm. Again, this innervation is right off the sacrum. S2 through 4 keeps the pee off the floor. So we all remember that. And this is what we're working with. You have the pubococcygeus, pubic bone to coccyx. You can see it. You want to palpate those deeper structures. Again, it's one digit assessment, no speculum needed. Iliococcygeus, ilium to coccyx versus coccygeus, right off the coccyx, and it follows a ligament. Piriformis, deeper, rotator of the hip, versus obturator internus, which is a big muscle for trigger points. And the arcuus tendinus levator ani, that little ligamental area is right by the obturator. You can also palpate the pudendal nerve. So the way you can find out where you're at, because you're blind visually, is having a patient externally rotate and palpating the obturator internus. So you're rotating with resistance, palpating the obturator internus, and therefore you're also feeling for the ligament and the pudendal nerve. So it might be helpful for you, especially if you don't have a speculum, to kind of have that visual and tactile cue. Now, with pelvic floor nerve innervation, this is so important, especially with scar tissue adhesions. And you can see all the cutaneous dermatomal pattern here. Now, the first one is the iliohypogastric, again, off of L1. And I see this commonly with suprapubic cesarean sections, repeat sections specifically, adhering deep into the bladder, causing all kinds of suprapubic pain, urinary frequency, and urgency. And I have to do a lot of scar work and manual interventions on this area. And sometimes I work with pain specialists who inject, and then I do manual interventions. Next is the ilioinguinal nerve, L1, L2. Again, I see vertical incisions, suprapubic incisions from a myriad of abdominal surgeries, and how the scar tissue can adhere and cause entrapment and irritation and pain. So this is a common area that I work on externally in the abdomen. Versus the pudendal nerve. Again, you can have trigger point injections not only internally but externally, and you can have different points of entrapment. So you have to look at all these different areas, vaginally and also externally at the obturator internus, and it's called the lobster claw between the two big ligaments of the pelvis, the sacrospinous and the sacrotuberous ligament. So you can see how the anatomy all affects. And if anyone has any questions, please raise your hand during the presentation. Now, next I want to talk about my manual interventions. Again, first you have to have a patient feel very comfortable, understand the anatomy, understand what you're doing and why you're doing it. And I do it as tolerated. I'm not going to hurt my patients. But the first thing is a myofascial release. There's different techniques you can do, internal, external. If the patient's in a lot of pain, you start externally, of course, and more dietary components. Versus connective tissue release, it's almost like skin rolling, where you're moving the adipose and the fascia over the muscle. And you can also do this connective tissue release to increase visceral mobility. I do visceral mobilizations of everything from the bladder, the uterus, the ovaries, large intestine, small intestine, because it's so intricately related to the pelvic floor. Contract, relax is rather nice, and I alluded to it earlier with that obturator internus. It's easy to palpate. You have the patient rotate out manually. Feel for the obturator internus with resistance. You're manually doing a myofascial release to the obturator internus for 30 seconds. And then you put them back into a resting position and go for further manual interventions. It gives more proprioception to your patients. They have awareness and how to relax and contract these muscles. A lot of times they're just so guarded, they have no awareness and don't know that there's any other pattern for them to hold that stress in. Again, scar tissue release is important to have things move freely, because everything moves freely in space. From the bladder to the uterus, the pelvic floor, everything has to move, so we need to work on scar tissue release. Perineal massage. After any kind of vaginal delivery, usually now most patients tear instead of episiotomies. This is a sensitivity, almost feels like dental floss, and you have to work on that, and I teach patients how to do this. A lot of times in an Epsom salt bath for an anti-inflammatory component, very easy, cheap anti-inflammatory Epsom salts. And Thiel's massage is another possibility, along with that coccyx mobilization I discussed earlier. Again, it's more of a distraction to put that coccyx in a proper position but then adaptive pillows so they don't weight bear on that coccyx, otherwise they're right back to the same position again. And then muscle energy techniques for SI torsion. Basically, you have patients contract the antagonist muscle, and you're stretching the agonist, and then setting the pelvis with ab and then adduction last. It works rather well, but if you have SI dysfunction, they're gonna have pelvic issues. Colon massage. You could even do this on a baby. It's pretty benign. It's something I can teach my patients. It's not a real advanced visceral technique. It's pretty basic. You can start at the cecum. So you could try it on yourself too for constipation. You wanna start at the cecum right side. It's clockwise maneuvers right here at the cecum, and you can go all the way up from cecum, ascending colon, transverse, descending sigmoid. This increases peristalsis, that gurgling. And I give them a myofascial ball, like a 4-inch ball, so that they can do this maneuver on themselves and cover more square area. So again, this is rather nice. And I get into more visceral techniques with opening different valves if needed, but that would be too complex to instruct a patient on. Now, we talked about biofeedback. I have 2 sensors I use, vaginal and rectal. I also use these for dilation in the beginning, and it doesn't scare patients as much. So rectal sensor can be used to kind of put slippery stuff on it, a water-soluble lubricant, and insert before an anal spasm. The vaginal sensor also is nice because the patient has a tactile, something to squeeze upon, so they have more idea of how to do a proper pelvic floor contraction. And then I get a nice graph here. Again, biofeedback doesn't measure strength. It measures the action potential of the muscle. And again, my goal is for them to hold a 10 count, relax for a 10 count fully, and do 10 repetitions. Now, this is a 20 trial. It gives a nice summary, so you can see that a patient can fully contract and relax. And this is important for continence. Now, next is neuromuscular reeducation. It's my Pilates base. So I want everyone to try this to make sure that you can do this properly. Put one hand on your chest, one hand on your abdomen. Now, the diaphragm is really the tool I use for anything. Now, if there's pelvic pain, you're not gonna do this. You do not wanna strengthen a muscle that's spasming and in pain. This is for once you're doing more strengthening. So I want you to breathe from the belly. Belly expands. And then exhale through the mouth. Squeeze the levator ani. You're squeezing anus and vagina. Then last, lower abdomen, where you can feel that transverse abdominis contracting. This is the foundation for Pilates and yoga. So I teach my patients, I call it Yogalates, because it's not strict yoga, it's not strict Pilates. Now, if there was a pain component, it would be more diaphragmatic breathing, looking at different dietary issues, constipation, manual interventions. This is only for more strengthening when no pain component exists. You may give this to your patients then. Diet, huge component. I want them to fill out this log for 3 days. I want to look at everything they eat and drink, how often they urinate, how often they defecate. When they urinate, I want them counting 1 Mississippi, 2 Mississippi, and record it down so I know how much they urinate rather than collecting the urine. Bowel movements. How often do they have bowel movements? Are they straining? What's the consistency? And I get into that later. If they had leakage, small is a drop of urine. Medium, start to wet the pad. Large is going through the pad and the clothing. And then urgency. Are they running to the bathroom? That's 1. Or I should say, 1, they feel some urgency. 2, they start to go to the bathroom. 3, they're running there and they have severe leakage in what they were doing at the time. So I want them to see these patterns as far as what they eat and drink, and also their bowel and bladder patterns, and then we'll discuss them. A lot of times patients realize what's going on, so then when I restrict their coffee and these irritants, they see them beforehand and realize what it's doing to their bowel and bladder. Also record the number of pads they use in a day. Bladder health. Again, a bladder can hold about 2 cups of urine. In a healthy bladder, at least 1.5 cups in my older patients. And again, I don't want them to void more than 6 to 8 times in a 24-hour period. I really don't want them getting up. It might be 1 time a night for maybe an elderly patient, but reduce that nocturia. They want that REM sleep. They want to sleep better. And I don't want them straining or hovering over the toilet. That'll cause a lot of pelvic floor issues. I tell them, if you're in public, just put toilet paper on the seat and sit and relax. Just breathe from the belly. and let it relax. Never strain or push your urine out. Again, I want them to know that urgency is a signal that the bladder's stretched. Doesn't necessarily mean that you need to go to the bathroom. No JIC, no just in case. We need to start retraining the bladder. And again, let them have more control and give them tools. And I'll show you some urge deference strategies I use for my patients. Again, good bladder tips. I want them drinking at least 40 to 64 ounces of water per day. Unless they're breastfeeding, then I'll up it to 90 ounces, but it's during daylight hours because I don't want them getting up at night. Limit their bladder irritants, and for IC we get really into this, but the big ones are the coffee, the teas, anything that's a diuretic, anything acidic too, such as pineapple or orange juice or grape juice, and sometimes tomatoes too. So they know that these irritants can cause acidity in the urine and cause more leakage because your bladder wants to get rid of these irritants. Then also alcohol is a huge one. It's a diuretic, it's acidic, and you lose that neuromuscular control. So the kind of all bets are if you're gonna have a glass of wine. But you could try Pre-Leaf. It's a supplemental over-the-counter item that neutralizes your food and drink. It also helps with acid reflux. So sometimes if they really want something, try the Pre-Leaf. Dilute the urine with more water, double the water afterward, and that seems to work well for my patients. Also, avoid constipation. It's so intricately linked to the bladder. So we need to go into soluble fiber, and I'll review that later, and cigarette smoking. So not only does it cause a myriad of cancers and bladder cancers, but it's an irritant to the bladder. So we talk to a patient about that, and at times they might want a referral to their internist regarding smoking cessation. Again, the goal of retraining is to make a more convenient pattern for a patient. And if they're every 30 minutes, then maybe I'll gradually increase it 5 to 15 minutes as needed, same time every day. And the goal would be 2.5 to 3 hours during the day and reducing nocturia. Again, just because they feel the urgency doesn't mean they need to go to the bathroom. And sometimes they'll have to do a log too, so they can see this and use their urge deference techniques. And just know this is a practice. Trial patient, you might have setbacks, but it's a process. In time, they'll have better control. Again, use the log, and the goal would be urination every 2.5 to 3 hours. And you can increase the time frame depending upon the patient, 5 to 15 minutes weekly. Again, a log could be used if necessary, so a patient can see their progress, or sometimes they put it on their phone for convenient usage. Urge deference. This is a great strategy for patients. You can tell them, so you feel the need to urinate. Doesn't mean you need to go. I want you to stand still or sit. Do a few quick contractions. Everyone try a few quick contractions of the pelvic floor. You're squeezing like you're stopping urination, or like you're going to stop gas, so you get that closure of the anus and the closure of the vagina. Next, I want you to breathe from the belly, what I taught you earlier. Breathe. Exhale and contract, and try to hold that endurance hold. That's your core stability, and inhibits the bladder. And a lot of you do posterior tibial nerve stimulation, but you can also manually do that stimulation. It's a reflex loop, Bradley's loop number 3, by rubbing the inner shin. You want to do deep palpation, rubbing the inner shin for at least 20 seconds, both sides. And a lot of patients like this, and it's kind of a quick fix for them. So I think that, that these techniques will work nicely for the patients. So you can see all these different urge deference techniques are a tool you give a patient. And it makes them feel like they have more control. Know their triggers, such as, a key in the door or water running, and then recognize that and do these techniques. It all can help a patient have more control and use their mind. That's probably the biggest distraction tool. Mindfulness techniques are helpful for my patients, and you can use a combination of all 5 senses. So they're very aware of their environment. They're slowly walking to the bathroom. They're not rushing, and they're going to slowly pull down their pants and sit on the toilet. These are specific keys because you don't want them in that sympathetic nervous stimulation, that fight or flight, because you're going to have leakage, versus parasympathetic innervation and activation. Again, when you breathe from the diaphragm, the phrenic nerve is directly linked to the parasympathetic nervous system. So therefore, use that system for your patient for urgency. Now, the next tool is a sleep longer protocol. Everyone wants to sleep better at night. So therefore, you want to reduce dependent edema. I love exercise balls or Swiss balls for core stability, but they could just put their feet up on a chair. Assuming there's no other, congestive heart failure or other medical issues, they can use this technique. Again, elevate, but the key is they have to perform this exercise 2 hours prior to bed in order to reduce the dependent edema. So this is an important concept they understand. They can do simple things like ankle pumps. And if it's an exercise ball, they can roll the ball in and out, and you're doing hip and knee pumps. Last, they can do their exercises I gave them, where they're doing the coordination of the breathing and the pelvic floor, lower abdomen contraction with some hip accessory strengthening too. Again, it only takes about 15 minutes of exercise, done 2 hours prior to bed. And then, if they want to go to bed at 10 o'clock, they'll do these exercises at 8 o'clock from 8 to 8:15, sit on the toilet at 9:55. Tip forward to bring that bladder anteriorly. I want them to empty with their diaphragmatic breathing. Maybe go from sit to stand, sit down again, and tip forward. This is an important concept to empty without straining, and then allows for better REM sleep. So it significantly makes a big difference, along with weaning down on fluids after dinner time. The bulk of your fluid should be during daylight hours. Fiber facts. So we talked about constipation and how it's so important to maintain regular bowel movements. And I tell patients what soluble fiber is. Like corn, for instance, is not soluble. It comes out in your feces. We're not rabbits. We don't digest that cellulose. So let's get things you can digest, such as fresh fruits and vegetables with their skin, freshly washed skin, and whole grains and cereals. High fiber with an increase in water, otherwise they become gassy. So that's a really important component. And eat less processed foods. Whole foods. Dr. Driscoll talked about 25 to 35 grams of fiber, but I say 3 to 5 servings because it's confusing for patients. It's like an apple's a serving of broccoli. If they get gassy from the broccoli, make sure they cook it well in the microwave. With beans, make sure they soak them well so that they don't become gassy also. And kind of eat maybe 2 servings with each meal, and that'll help fill them. So it's a good dietary component, and it'll produce more soluble fiber and a softer stool. Again, here's the soluble fibers: fruits, apples, pears, oranges, vegetables. If a patient can eat them raw, then cooked. Seeds, oat bran, dried beans that are very much soaked so that they don't become gassy. Simethicone might be an option too for them. Oatmeal, barley, rye, and prunes, good old prunes. And I also have a little recipe for patients if they need a little extra. It's prune juice, applesauce, and oat bran. They make it in a big container and eat a few tablespoons nightly, assuming they're not diabetics and it's not, they don't have a problem with their sugar levels. This is a good supplementation for fiber. Again, with fiber, you need to have water. 64 ounces of water, 3 to 5 servings of fiber. Again, whole foods. So, you've seen this before, the Bristol stool scale. I want the Goldilocks poop. That is number 4. Okay? Everybody wants the Goldilocks poop. It's just right. It's not too hard. It's not too soft. And I make patients understand this is so important. If you're straining with that number 1, rabbit turds, basically, you're going to have tons of prolapse of organs. You're going to have varicose veins and hemorrhoids and all kinds of issues. So you want to prevent straining. And patients have to understand they need to prevent straining to protect the repair site, to reduce urinary urgency and frequency. And some of my patients are just the opposite. They're too loose. So then we have to talk about soluble fiber like the brat diet, bananas, rice, applesauce, and the tannins and teas, and how to bulk up their stool. So you have to see this whole gamut here. Remember, the Goldilocks poop is just right. Number 4 is what you want. God bless you. So again, I get into defecation postures and techniques because patients sometimes don't know how to move their bowels properly, especially some of my GI patients, and they have no awareness. And even for children, you need to have your feet on the ground. I recommend a step stool or a squatty potty. I do not have the patent of the Squatty Potty. I wish I did. But by changing the anal-rectal angle with the knees above the hips, it's a nice smooth bowel movement. And again, we're going to use that intra-abdominal pressure. So again, I'm going to use that diaphragmatic breathing. I use it for a lot. Again, I want them to breathe from the belly. Belly expands. You want to hold intra-abdominal pressure, 20 to 30 count. The idea is to push the feces down into the canal without straining. And then this is the beginning of the tube. The end of the tube is the anus. So when you exhale, open mouth. Really important. Do not clench the mouth. Open the anus. And again, you need to sometimes tilt the pelvis back and forth, side to side. We can play with different positions for the patient. So think about that with your patients on how to change their defecation postures and techniques. Dilator home program. Love Amazon Prime. This comes directly to their home, so they don't have to worry about ordering this. With slippery stuff. I want a water-soluble lubricant. I'd recommend slippery stuff because I've never had anyone have a reaction to it. Again, they're going to sit in a semi-reclined position behind closed doors. No one's bothering them or knocking on the door and screaming, "Mom." And again, they want to gradually stretch the pelvic floor muscles. Again, that pelvic clock that we discussed earlier. A lot of times, I just have them start maybe just like half an inch, right at the posterior fourchette, and that is 6 o'clock. Okay, versus 12 is the urethra. Stay away from the urethra with this because you don't want to irritate that structure. And they can go to different points. They can go to 3, they can go to 9, and they can go sometimes from 6 all the way up to 1, and then 6 all the way up to 11. I like both of these techniques. Dilators would be more for maybe vaginismus or dyspareunia versus the pelvic wand is great for trigger point releases. I can teach patients different techniques. I can do the manual intervention, usually say my patients weekly, but how can they do this daily? That is the key to maintain progress, and therefore they have to use their dilator series. And some are quite apprehensive. They won't even open the box until they get into the clinic with me. Like, I didn't want to open it unless you're with me. So, you know, just make them understand this is not sexual. This is a medical instrument. It's just a stretch, like you might stretch your bicep or your hamstrings. And it should never cause pain. You're never poking or prodding. It's gentle. I also use modalities. Now you can see this STM10, and there's different parameters. Now I know you use posterior tibial nerve stimulation. I just discussed with Mark outside. They use 20 hertz versus I use a lower hertz, 12 hertz for urgency. And again, I use a vaginal sensor. It stimulates the pelvic floor and helps reduce urgency for a lot of my patients. And they've had that with their posterior tibial nerve series, and they've increased the length between urination from 30 minutes. Now she's at 2.5 to 3 hours, so she's quite pleased because she's functional. She can go out in public and garden and, you know, go to the grocery store. Versus if there's more of an incontinence issue, then I like 50 hertz for strengthening. It helps overflow and contraction of the pelvic floor musculature when there's true atrophy and weakness. Versus pelvic pain. Now this is a higher buzzing sensation, and you can it buzzes, and it's more for pelvic pain. It helps block the pain signals in the gate of the substantia nigra before they come up the spinal column and interpret in the brain. So you can see this is another adjunct we can use, a modality such as STM10. Ultrasound, great for scar tissue adhesions before doing manual work. Again, this doesn't produce an image, this causes vibration, a deep heating at the perineum or in the abdomen for scar tissue. Now, if it's the perineum, I use a condom because it's cheaper than an ultrasound cover, gel filled, and then I do it pulse because it's a very small square area. And you can see the parameters there versus at the suprapubic area or even with a vertical scar tissue adhesion. You want to do a more continuous ultrasound with a higher intensity of 1.2 watts per centimeter squared. So again, this is helpful to warm the tissues before I do my manual interventions. Now, this is a nice assessment tool. I don't know if anyone uses the PFDI-20 already. It's only 20 questions, and it gives you a synopsis of pelvic floor issues. And you can see the grading scale. If it's yes or no, no is 0. If it's yes, you can see from not at all, somewhat, moderately, versus 4 is quite a bit. And you score this, and this gives you a limitation score. And then here are the categories. You can see the first one is pelvic organ prolapse, everything from pain in the lower abdomen to heaviness to you ever having to push or splint on the vagina, to have a bowel movement, incomplete emptying of the bladder, or push up again in the vaginal area to start or complete urination, versus colorectal anal distress. Do you ever feel like you need to strain to have a bowel movement? Do you feel like you haven't completely emptied your bowels? Is your stool ever, do you ever have fecal incontinence with a loose stool versus maybe a fully formed stool? And do they have bowel urgency, or does the bowel ever pass through with a bowel movement? Again, there's some more prolapse components there. Versus urinary distress. Does the patient have frequent urination? Urgency. Stress incontinence with coughing, sneezing, laughing, running, jumping. If they have difficulty emptying or experience pain in the abdomen or genital region. Again, what you do is you total each section and you multiply by 6, multiply by 25 and then divide it by 6. And you can get a limitation score per each section and then total them up out of 300. And this is something that's been proven as a functional outcome measure for efficacy. So you can use this at evaluation and discharge. You can see an objective number at discharge. And again, I want to show you a case. Dr. Jersley talked about this patient earlier. We both saw her, and she had urinary urgency, frequency, and levator ani spasm. And she was 60 when I first started seeing her, and then had a birthday. She turned 61. She had frequent urination every 30 minutes, okay? And she couldn't do anything. She couldn't volunteer. She couldn't grocery shop without knowing where the bathroom was at all times. She had incomplete emptying. That's why she had such frequency. Abdominal bladder pain, suprapubic pain, 4 out of 10, and 9.5 out of 10 rectal pain. So she was in a lot of pain. She also had some chronic constipation and pain with palpation of the cecum, the gallbladder area, the bladder, and the right ovarian area because there was a ruptured cyst. So all on that right side, there was more complaints. And then internal vaginal assessment revealed 3 out of 5 levator ani weakness with only 2 count endurance. But she was guarding. She was just always so taut and had trigger points on the right side again, right obturator internus, the right piriformis, and also some right hip problems, greater trochanteric bursitis. Rectal assessment, she also had spasming of that external anal sphincter and the puborectalis, and trigger points at the coccygeus muscle. So everything was just so guarded and painful. And the first day, I just gave her diaphragmatic breathing because we want parasympathetic nervous stimulation. I want that phrenic nerve activation, and then eventually progressing to maybe a bulge or a drop in the perineum where there's an opening of the anus and vagina with exhalation. Then eventually, once the pain component subsides, then you can begin the strengthening. But in the pain component side, the acute phase, it's more manual intervention, yoga breathing, mindfulness, all these techniques to down-train the nervous system and biofeedback. Again, you can see PT will concentrate, like a synopsis overall, is to normalize urinary frequency, pelvic floor tone, we want that normal, and increase soft tissue mobility of the viscera and all the musculature to allow for complete emptying of the bladder and the bowels. Treatment progression. Again, the diaphragmatic breathing, she progressed now to bulging, opening up the anus and the vagina with exhalation to down-train the system. Again, it's not a strain, it's just an opening with exhalation. Colon massage, I showed you earlier. I do it on the patient. I also do some visceral techniques, but they can use that myofascial ball to stimulate peristalsis, along with those defecation postures and techniques. Internal vaginal myofascial release at the obturator. Specifically, I told you about that contract, relax technique to gradually release the musculature, and then teaching a patient to use that first wand, that Thera wand or the Pelvi wand, at that trigger point with sustained pressure and gradually release that muscle. Again, down training with the biofeedback. I don't want them contracting. I want them relaxing. I want their pelvic floor probably under 2 to 3 microvolts vaginally and maybe under 5 rectally so they know they can fully relax. Then topical vaginal estrogen is a must in my postmenopausal patients because it plumps up the tissues. I've seen visible differences. It's no longer atrophied and white. It is pink, it's plumped. I can strengthen those tissues. There's good lubrication. It's so important in order to progress my patients, along with vaginal Valium. Again, nightly, warn your patients. It's neon colored. They insert the pill vaginally, put their old underwear on. I like that at night because then they're not standing. Gravity tends to work its way out, so this keeps it in the vaginal mucosa. And this is important so I can do my therapy and do the manual work. Again, bladder mobilizations and connective tissue release to the lower abdominal quadrant to release all that viscera in the lower quadrant, and avoidance of bladder irritants and progressive bladder training, along with training in soluble fiber and defecation postures and techniques. So this patient proceeded to have 3 Marcaine injections, so an anesthetic injection, mostly to the obturator internus, that's right where the pudendal nerve lives, and the coccygeus muscle. And I kind of pain mapped these two for Dr. Jersley so I could see these different points of restriction. Again, the right side was worse than the left. And more visceral mobilization of the cecum and training on those postures we talked about with defecation, dietary soluble fiber. So important. Again, everything from benefiber to, oral fiber, about 2 servings with every meal. But she was seeing a GI physician also who prescribed Linzess, magnesium citrate, and Miralax, which is a reverse osmotic laxative, and a lot of my patients will use that. Also, yoga hip stretches and Therawand or Pelviwand to self-release. Colon massage we discussed with the ball, and progression of the diaphragmatic breathing. This time now I'm able to strengthen her. She's able to contract pelvic floor, lower abdomen with exhalation. And then I proceed on different positions from supine to seated to standing and then more dynamic positions. And some of my patients progress to a yoga Pilates program and a whole flow depending on where they're at in their fitness level. Mindfulness. This patient had a history of depression. She was also having TMS treatments at Rush for depression. So mindfulness so that she doesn't carry all of her stress in her pelvic floor. Like some people carry their stress in their upper traps, it can happen in the pelvic floor too, to relax and down train. So this is another key from a mind-body connection. And myofascial release of that obturator internus and deep levator ani. So you can see a progress here. Patient is doing quite well. Now she's urinating every 60 minutes. She's had quite a few trigger points, 2 trigger point injections, a reduction in nocturia to 1 to 0 times a night. This is huge for a patient. She's sleeping better. That's big right there. Going to the bathroom less often, able to do a few errands without having to run to the washroom constantly. Again, we're doing that same manual intervention that we discussed with myofascial release and contract, relax of different muscles, because I want them to know what this muscle should feel like, how it should feel contracted, how it should feel relaxed, and then do the manual intervention. And I ordered the restrictions. Again, right coccygeus and pubococcygeus were really trigger points, and obturator internus on the right more than the left. And these were the areas of injection. Again, a home exercise program, yoga stretches, which are fantastic, but very modified stretches depending on where my patient is. Colon massage, the Dilator or Pelviwand, myofascial release nightly. Now here's her discharge summary. Again, she actually is 61 by this point, but her pain rectally went from 9.5, and now it's 1 out of 10. Huge. She doesn't have that 4 out of 10 bladder pain either. Her frequency in urination decreased from 12 times to 7 times a day. It's functional. Huge quality and life changes. Nocturia is 1 to 0 times a night. That's functional. You're sleeping better. Again, that PFDI, I recommend using that form for a quick synopsis of your patients and how they're doing. She went from a limitation score of 78 out of 300 at evaluation to 29 out of 300. And she understands this is a maintenance program. This is something she has to continue with. Again, I give her the tool. She may have a flare, and she knows what to do. Sure, go ahead. So like 300 and 300 is full limitation. They scored a 4 out of 4 on every category. And there's different categories and limitations. Like they can range from 60 to 80 to 40 to 60 and down the line percent disability. So it depends on a patient's frequency and sometimes how they interpret the scale, but it's a nice objective measure. So normal, it could be around 78 to, it depends on the severity, I guess. 78 to 100, had some come as much as 150. I rarely have anyone that scores a 300. That's unusual, to be honest. I'm looking for objective improvements. So not only do I see it, they know it, they're better off, but this is nice for insurance purposes. I have a number for them, okay? And you can, I'm sorry? Where can you find it? So now you can find this online anywhere, but you can also have access to my slides, but I know I couldn't put it all on one slide so you could visually see it. So it's called the PFDI-20, and I highly recommend that. And all my slides too you could use for your patients and modify them if needed. So you can see how it's a very collaborative effect with all these different disciplines, from pelvic physical therapy, all these different disciplines serve our patients' needs, to a dietitian if there's more IC or celiac disease, our physicians, our urogynecologists, obstetricians, our urogynecological nurses that do the dynamic testing, urodynamic testing, posterior tibial nerve stimulation, complementary medicine, mindfulness, a huge component of the mind-body connection, great for chronic pain too. So I really recommend that. Counseling, if there is an abuse situation, this is mandatory because that causes all kinds of pelvic floor dysfunction. You have that mental and physical manifestation. Wellness program, how to manage their pelvic health. A general wellness program, pain management. I sometimes work with our pain specialists with injection series in conjunction with therapy. Support groups for IC or celiac disease can be helpful for our patients to empathize and sympathize with others with similar conditions. So you can see all these different components all help serve our patients' needs in order to meet their goals. And it's kind of a collaborative effect. And I wanted to introduce our pelvic health team. So now there's 3 of us at the Plainfield North facility, myself, Lisa Furto, and Pramila Martin. Again, we're at Route 59, 127th on the 2nd floor of the ED. Next, we have Melissa Fee and Jennifer Wright. They're at the new iMed building off of 75th Street and Route 59 across from the Forest Preserve. Beautiful new building. And then last, I have Natalie Florio. She is in Southern Naperville off of Forge Drive, right by the Wingstop. So you can see, again, we have 3 locations, 6 clinicians to meet your patient's physical therapy needs. And here's some references for your information. And I'm trying to see if there's a PFDI in here. If you just research PFDI-20, you can pull up that form and you can just print that off. So it's very helpful for that. And does anyone have any questions for me? Yes. At this clinic, I do not yet. We might expand out into men and children, but this time, no, it's just women's health. Any other questions regarding the slides or techniques, use of physical therapists? No? Hopefully, as this was a synopsis of pelvic physical therapy and how it can help your patients, and you have more awareness. And thank you for your time. I'm glad it didn't snow. Yes. Oh yeah. Yeah. Do you have another question? I've treated even severe prolapse where it's like grade 4. Because if they want conservative management, we're looking at anti-gravity positions, pessaries, and estrogen-based creams. So again, a strengthening program. Oh yes, definitely. I do it all. If there's no awareness, then I use that STM10. So, yeah, sure.